Today, I will provide information about how the second wave of COVID-19 is affecting Halton and how public health is adjusting its response. This presentation was prepared with the aim to address many questions that have been recently asked by residents of Halton as well as yourselves. Next slide, please. So I'll start by sharing some epidemiological data. You'll see a lot of graphs over the next several slides. This graph shows the number of new cases of COVID-19 reported per day among Halton residents over the course of the pandemic. By the end of day on October 19th, 1,872 cases of COVID-19 had been diagnosed among Halton residents. This includes 233 active cases at the moment and 30 deaths. The 7-day rolling average peaked in April, and that's the blue line that you'll see, and then began to decline and remained low over the summer. The 7-day average then began increasing again in September, rising to a new all-time high on October 14th, when that 7-day average reached 36.6 cases per day. That day, 47 new cases were reported, and within the preceding 7-day window, we had days with 56 new cases reported on October the 8th and 52 new cases reported on October the 9th, records for Halton so far. In total, between September 1st and October 19th, 889 new cases were reported for Halton residents, almost as many as were reported between March 1st and August 31st. Next slide, please. A recent science brief released by the Ontario COVID-19 Science Advisory Table suggests that since testing is much more accessible now than it was earlier in the pandemic, the number of new cases per day cannot be directly compared between what is going on, what is now being called the second wave, to determine if it is as severe or more severe than what we experienced in the spring, now referred to as the first wave of the pandemic. Instead, the focus really should be on the slope of the 7-day rolling average. You can see that the slope of Halton's 7-day rolling average is now very similar to the slope in wave 1 and suggestive of exponential growth. The slopes are highlighted on the graph with the red arrows. Next slide, please. The same science brief indicates that additional public health measures should be considered when there are more than 25 new COVID-19 cases per 100,000 population per week. Sorry, for whoever's controlling the slide deck, I think you've gone one far too ahead. Can you please go back to slide 4? Thank you. So when that weekly rate is higher than 25 new cases per 100,000, the brief recommends restricting indoor activities where it is difficult to wear masks and or in which physical distancing is difficult to maintain. For example, indoor dining, banquet halls, gyms, bars, clubs, and casinos. In addition, people should be encouraged to work from home if possible and to leave home only for essential activities. The brief suggests that schools should be kept open as the number and extent of school outbreaks has been low to date. At the time the brief was prepared by the Ontario COVID-19 Science Advisory Table, only Toronto, Ottawa, and Peel were meeting this threshold, and the recommended closures were implemented on October the 10th in those health unit areas. These restrictions were also recently implemented for York Region. However, our more recent local data show that Halton exceeded this threshold, shown in this graph with the red line, for the week of October 4th to 10th, when 39.6 new confirmed cases were reported per 100,000 people. The rate remained above 25 per 100,000 last week as well, the week of October 11th to 17th, when there were 32.5 new confirmed cases reported per 100,000 people. As such, even without additional closures in Halton coming from the province, I recommended additional public health measures such as the suspension of all team sports scrimmages and games and the temporary pause of indoor fitness classes. The brief emphasizes that comparative evidence from other countries suggests that early targeted public health interventions can prevent the need for more stringent public health measures further down the line. It's also important to note that when such measures are introduced, it takes 10 to 12 days at a minimum before their impact is observed in terms of the number of new confirmed cases. Next slide, please. Consistent with the finding on the previous slide, this map of health unit areas in Ontario, taken from a report produced by Public Health Ontario, shows the weekly rate of infection in each health unit for the week of October 4th to 10th. Halton, Hamilton, Peel, Toronto, York, and Ottawa were in the highest incidence rate category on the map, which is marked as darkest blue. And these were all having a weekly incidence rate greater than 30 new cases per 100,000 population. Next slide, please. To understand how wave 2 has unfolded compared to wave 1, this slide shows the cumulative case count in Halton broken down by age group. You can see that beginning in September, the number of cases among the 0 to 19 age group in green, the 20 to 39 age group in purple, and 40 to 59 age group in yellow began to sharply increase, while cases among older adults, 60 to 79 in orange and 80 plus in blue, have experienced less change. This tells us that the increasing rolling average and weekly rate we saw in the previous slides was primarily driven by new cases among people under the age of 60. This is consistent with provincial trends. However, you can also see in the graph that in October, the case counts for residents aged 60 to 79 and 80 plus began to rise, which is troubling. We know older adults in our community are at a higher risk for poor outcomes related to COVID-19 and are more likely to require healthcare services, hospitalization, and ICU beds. Indeed, of the 30 deaths among Halton COVID-19 cases to date, none have occurred among residents under the age of 40, and the majority have occurred in residents age 80 or above. Next slide, please. This trend means there are some differences when comparing the demographics for the second wave so far to some parts of the first wave. Please note that the Halton population in 2020 is provided on the far right side of the graph for reference. Residents aged 0 to 19 accounted for 28% of new cases in September, when they had never accounted for more than 20% of new cases in any previous month, despite accounting for 24% of the population here in Halton. Residents aged 20 to 39, on the other hand, accounted for 47% of new cases in August and 42% of new cases in September, though they accounted for just 26% of our population. Residents 80 years of age and over accounted for 19% of new cases in April during the first wave, a month hard hit by institutional outbreaks, but accounted for only 1% of new cases in September. The proportion of new cases aged 80 plus so far in October has now risen to 11%. Residents age 80 plus account for only 4% of the Halton population in the year 2020. Next slide, please. We know that increased transmission in the community also results in an increased risk of outbreaks among the vulnerable in institutions, defined here as long-term care homes, retirement homes, and hospitals. Consequently, the number of institutional outbreaks in Halton throughout the pandemic has followed the pattern of cases, but with some delay. This graph shows the number of outbreaks active each day between March 1st and October 19th. School outbreaks are also included in this graph. The first institutional outbreak was declared on April 1st, almost a month after the first case in Halton, in a Halton resident was reported. There was a period of time over the summer with no active outbreaks. Throughout the fall, however, a number of new outbreaks have been declared, primarily in long-term care homes and retirement homes, which account for many of the cases aged 80 plus shown in the previous slide. In total, 33 outbreaks of COVID-19 have been declared in Halton institutions, and 1 in a Halton school since the start of the pandemic. Of the 33 institutional outbreaks, 4 were declared in September and 7 were declared in October. As of October 19th, there are 6 active institutional outbreaks with 65 Halton cases among them, a mix of staff and residents. This does not include staff of these institutions who may be part of the outbreak, but who live outside of Halton. Next slide, please. The number of inpatients at Halton hospitals with confirmed COVID has also followed a similar pattern to cases, but we know that the occupancy of hospital beds increases with a time lag of several weeks. This reflects the delayed spread of COVID-19 infections to more vulnerable people, as we saw earlier with the delayed rise in case counts for older adults and the delayed onset of outbreaks in our institutions, as well as the delay between the diagnosis of COVID-19 and the experience of severe effects that lead to hospitalization, which can be a couple of weeks apart. The number of confirmed COVID-19 cases occupying a bed in a Halton hospital peaked at 26 in April, then began to decline, with some days with no COVID-19 inpatients over the summer. However, as part of the second wave, we have begun to see more beds occupied by confirmed COVID cases again. On the most recent day for which data are available, October 18th, there were 6 inpatients in Halton hospitals with confirmed COVID-19. It's important to remember that not all of the individuals hospitalized in Halton are necessarily Halton residents, and similarly, Halton resident cases may be hospitalized outside of Halton, somewhere else in the GTA. The science brief mentioned earlier predicts that with the absence of more stringent public health measures, this trend of increasing hospitalization of COVID-19 patients could lead to ICU occupancy reaching the threshold of 150 beds in Ontario by late October, which would likely result in cancellations of elective surgeries. Next slide, please. I want to take a minute now to talk about deaths from COVID-19. Let's not forget in talking about cases and hospitalizations that this is in fact a deadly disease with a mortality rate significantly higher than many other viruses, including influenza. We should never lose sight of this when talking about why we are asking for the community to take extra precautions. We were lucky during the first wave that we were able to avoid the death toll that was predicted because of the quick actions in this province. This slide shows the number of new deaths reported each day since the beginning of March. Similar to hospitalizations, the number of deaths among COVID-19 cases was somewhat delayed relative to case onset, with most deaths occurring in April and May following increased outbreak activity in Halton institutions. After experiencing no new deaths since June, leaving our total death count at 25 for a prolonged period, there have been 5 additional deaths among COVID-19 cases in Halton since the beginning of October, all among residents in the 80 to 80 plus age group and associated with the recurrence of institutional outbreaks. This has raised the total death count to 30 and demonstrates how spread within the community ultimately leads to infection in more vulnerable individuals. Next slide, please. You may wonder if all this COVID-19 activity could simply be an artifact of increased testing. The green bars in this graph show the number of Halton residents tested. You can see that testing was indeed quite high in late September, with almost 12,000 Halton residents tested in the week beginning September 20th. The numbers have decreased in more recent weeks, likely due to the introduction of policy changes to limit the testing of asymptomatic individuals. However, the increased case counts are likely not just a result of more testing, as indicated by the orange line, which shows the percentage of tested Halton residents who had positive results, also known as percent positivity. This metric has also been increasing, with 2.5% of Halton residents tested in the past week of available data having positive test results. Some regions in the province have experienced percent positivity above 3%, which according to the Ontario COVID-19 Science Advisory Tables brief is an internationally accepted benchmark used to distinguish regions with and without sufficient control of the pandemic and adequate testing capacity. According to the Science Brief, studies in some parts of Ontario, such as Toronto and Ottawa, have also shown steep increases in COVID-19 detection in wastewater, which is unaffected by testing backlogs or changes in testing practices, unlike the case counts and testing numbers, and therefore suggestive of a true increase of COVID activity in the community. Next slide, please. So far, these slides have demonstrated that we are experiencing a second wave of COVID-19 and that it is beginning to expand to vulnerable populations and affect our healthcare system. Of course, the question on everyone's minds is where these infections are occurring and whether that looks different in the second wave compared to the first. This graph shows the proportion of cases in each primary exposure group per month. The primary exposure group captures the case's most likely source of acquisition. That is contact with a known case, an outbreak, travel outside Ontario, or a known link that is not yet specified. Community cases are cases who do not have a clear source of acquisition, so they are presumed to have acquired the infection through broad community spread. For new cases reported in March, travel was the most common primary exposure group. With the restrictions put in place, travel has become a relatively rare source of exposure. Increasingly, cases are most likely acquired their infection from a household contact or other close contact known to have COVID-19, including 60% of new cases reported in September and 53% of new cases reported in October. This is likely related to increased socializing and interaction with others following loosened restrictions in the summer or through interaction with a household member who acquired the infection elsewhere. The proportion of cases whose primary exposure group is outbreak is also beginning to increase again, rising to 17% of new cases in October so far, consistent with the outbreak activity shown previously. Next slide, please. So the next two slides delve into this topic more deeply by providing an overview of the common types of locations where COVID-19 exposures have occurred since September 1st. Transmission exposure locations are places where a person with COVID-19 may have exposed others to the virus. This information is collected by public health from people with COVID-19 by asking them about all of the locations where they may have to come into contact with people during the period of time when they were deemed to be contagious. This process helps us with contact tracing, that is, identifying possible close contacts of cases that need to be isolated. The size of the bubbles represents how common it is for a person to have visited a location in that category at least once during the period that they were contagious. One person may have visited locations in multiple categories and are counted once per category. However, just because a person was at this location while they were contagious doesn't necessarily mean that they passed the virus on to anyone else there. There are also limitations with the data presented that must be considered, and results should be interpreted with caution. The information we have available is dependent upon what a person remembers and discloses to public health. It is also important to keep in mind that the system we use for COVID-19 case and contact management is relatively new and undergoing constant updates, and staff are still learning how to capture this complex information in the new system. The most common transmission exposure location was the case's own home, where they exposed others who they lived with, followed by private social gatherings. Most private social gatherings in this category reflect instances where a person may have visited the home of friends or family while they were contagious, or where they may have had someone visit their own household while they were contagious. This category includes private social gatherings of any size, from one visitor to larger parties. If you recall, the previous slide showed that contact with a confirmed case of COVID-19 is the most common primary exposure group. So it is not surprising that private homes and social gatherings are the two most common transmission exposures that we see to date. The third most common category is entertainment and dining. The majority of exposures in this category occurred at bars or restaurants, followed by wineries, breweries, and banquet halls. There are also a small number of indoor entertainment facilities like a bowling alley and movie theaters. The fourth most common category, other business or workplace, includes various business locations like construction, manufacturing, offices, or other workplaces. And the fifth most common category, gym, fitness, recreational facility, includes gyms, fitness studios, arenas, and other sports and recreation facilities. It's important to note that many of these categories might also be considered social gatherings, such as traveling with or dining at a restaurant with individuals outside of the person's household, or weddings and other special events being held at banquet halls or wineries. These locations may also be the case's place of worship. Case's place of work. Next slide, please. Acquisition exposure locations are places where a person with COVID-19 may have been exposed to or acquired COVID-19 in the period shortly before they became sick or tested positive. The categories are the same as the transmission exposure categories described on the previous slide. This information is gathered during case investigation by asking a person about places they may have visited in the days before they developed symptoms or tested positive for COVID-19. Similarly, the most common acquisition exposures were a person's own home, a private social gathering, or an entertainment or dining location. Again, it's important to note that people have often visited multiple locations prior to becoming a case, and it is often not possible to determine the exact location where they most likely acquired the virus. However, as cited in the Ontario COVID-19 Science Advisory Table Brief, a recent study in the United States found that individuals with COVID-19 who had no known contact with a positive case were significantly more likely to have dined at a restaurant or visited a bar or coffee shop during the previous 2 weeks compared to people who were also tested but found not to have COVID-19. Next slide, please. We have seen that COVID-19 more severely affects the most vulnerable in our community, such as older adults, but we must also consider other sources of vulnerability. Since July, Public Health has been collecting information about the social determinants of health, including cases as first language learned in childhood, race or ethnicity, and household income. This information is missing from many cases for a variety of reasons. For example, the case did not feel comfortable providing the information, or the case was too ill to provide this information. The data are considered preliminary at this time, and there may be other important biases or differences between cases with and without missing information. For example, cases missing the information may have been more likely to be hospitalized. Testing of people from the same family or who live in similar areas can also produce clustering of similar characteristics. Finally, there are some differences in the way this information is collected for COVID cases compared to residents in the census, and there may have been shifts in the demographic makeup of Halton since the 2016 census. For first language specifically, the information is missing for 25% of Halton cases who do not reside in an institution and who were reported July 1st or later. Excluding these individuals, you see in this graph that about 63% of Halton COVID cases, shown in the darker green, have had English, French, or both as a first language. This is lower than would be expected because in the 2016 census, 75% of Halton residents said that English, French, or both were a mother tongue. This means that a higher proportion of our cases, about 37%, did not have English or French as a first language, compared to 25% of the Halton population as of the 2016 census, saying that they had only a language other than English or French as their mother tongue. Next slide, please. For race, the information is missing again for about 25% of Halton cases who do not reside in an institution and who were reported July 1st or later. So again, this data must be interpreted with caution. The information is collected for COVID cases by asking about race, whereas for the census, it is collected by asking if the respondent is a visible minority. Keeping this difference in mind and excluding the missing individuals, you can see that the graph in this graph that about 58% of Halton COVID cases, shown in darker green again, were not a visible minority, meaning that they said that their race was white only. This is lower than would be expected because in the 2016 census, 74% of Halton residents said that they were not a visible minority. Conversely, this means that a higher proportion of our cases, about 42%, said they were a visible minority, any race other than white, when only about 26% of the Halton population as of the 2016 census was a visible minority. Lastly, there is a high amount of missing data for household income of COVID cases in Halton, with this information being missing in about 52% of our cases since July. As such, we're unable to share that information with you at this time. Next slide, please. Public health is also considering the indirect impacts of the COVID-19 pandemic. Since the beginning of the pandemic, many community-based measures have been implemented to limit the spread of the virus, such as travel restrictions, social distancing requirements, quarantine protocols, and the closure of non-essential services. During this time, some community and public health services in Halton have also been scaled back or temporarily suspended. Community-based measures, while important for controlling the spread of COVID-19, can also have unintended indirect impacts on the health and well-being of populations. Recent media coverage and emerging evidence have begun to highlight some of these impacts. Examples include poor mental health outcomes, increased household food insecurity, reduced physical activity, and challenges accessing healthcare. These are important areas that public health is monitoring through various data sources, including an online survey through the Rapid Risk Factors Surveillance System. This survey will collect information on how the pandemic has impacted the health, behaviors, and well-being of Halton residents. This information will be used to identify priority populations who may be faring worse during the pandemic and to identify areas that require attention by public health and various community partners and organizations. Next slide, please. In response to the second wave, both Ontario and Halton have made adjustments to public health measures in an effort to once again flatten the curve. The province has paused social circles, reduced social gathering limits to 10 people indoors, and restaurants and bars changed in dine-in hours for serving alcohol, and closed strip clubs, developed online screening tools, one for workplaces and one for childcare centers and schools. The province also added mandatory masks to the regulations, although, as you know, we already have a comprehensive mask bylaw in Halton. In addition, the province is now promoting the message, limit trips outside of the home, except for essential purposes only. I'd like to note that where cases are highest, the province is also applying extra public health measures to specific regions. Currently, these areas include Ottawa, Peel, Toronto, and now York. As I mentioned earlier, international studies show that early targeted public health measures aimed at specific environments or locations associated with increased transmission of COVID-19 can prevent the need for more stringent public health measures further down the line. I'd also like to share that together with my colleagues from other public health units, I continue to provide recommendations to the province. The reduction for social gathering limits was a great example of recommendations from medical officers of health being applied provincially. Next slide, please. In light of increasing case numbers, earlier this week, I released a letter to the community providing recommendations to our residents, businesses, and organizations to limit the further spread of COVID-19. In the letter, I asked all residents to limit close contact to people within their household and to limit non-essential activities. I also made specific recommendations for settings such as indoor fitness facilities, restaurants, and bars. I recommended that sports organizations train only and pause games or scrimmages, that people only dine in at restaurants with their own household members, and that fitness facilities consider pausing indoor fitness classes and take these classes outdoors if possible with adequate physical distancing. While we cannot avoid the second wave entirely, we still believe that together we can flatten the curve here in Halton. Next slide, please. Earlier this month, I shared an update with Regional Council that I had amended our Section 22 class order issued under the Health Protection and Promotion Act. The revised class order came into effect on October 5th. The revised order reflects recent changes in provincial guidance and some clearer language to emphasize the legal obligation of all to whom the order applies to remain reachable for monitoring by public health, and to share their names and contact information for all their contacts as requested by public health. This cooperation is essential for Halton Region Public Health to be able to assess and respond to risks of COVID-19 transmission across Halton Region. This change was communicated widely to the public through a news release, updates to our halton.ca website, and direct communications that were sent to local municipalities, school boards, childcare centers, long-term care homes, retirement residences, and other partners. Next slide, please. As you know, improving testing capacity and providing guidelines for testing comes from the province. In Halton, our hospitals are responsible for assessment and testing. And now, as part of the province's effort to improve access to testing, pharmacies are starting to test asymptomatic individuals. Last week, we started with 4 locations in Halton, 3 in Oakville, 1 in Georgetown. We expect more locations to be added over time. The ministry maintains a webpage for COVID-19 testing locations across the province. While Halton Region Public Health does not provide testing for COVID-19, we have received a lot of feedback about testing in Halton. We've continuously shared that feedback with our local hospitals, and we have heard from our local hospital partners that changes to the provincial testing guidance has helped with wait times and test turnaround times. My next slide will explain this new testing criteria. Next slide, please. On September 24th, the provincial government released updated COVID-19 testing guidance. Changes were made to prioritize those for testing who are at greatest risk while shifting away from untargeted asymptomatic testing, which I had spoken to Council about last month. The updated guidance recommends the following individuals to be tested at an assessment center: individuals who are symptomatic, those who have been exposed to a confirmed case of the virus as informed by local public health or exposure notification through the COVID-19 Alert app, residents or those who work in a setting that has a COVID-19 outbreak as identified and informed by local public health, and those eligible for testing as part of a targeted testing initiative directed by the Ministry of Health or the Ministry of Long-Term Care, such as long-term care home staff. Testing of individuals who are asymptomatic or who have had low-risk exposures is not recommended at this time. Next slide, please. As you are well aware, since the beginning of September, there has been increasing number of COVID cases here in Halton Region. On September 1st, the 7-day rolling average was only 3 new cases per day. As of October 19th, it is 32 new cases per day. As phase 3 allows for more businesses to be open and some residents are not necessarily following public health recommendations of physical distancing with others, many cases have more contacts than in the first wave. I will speak to this in the next slide. We're also faced with increased community and workplace transmissions. On average, 30 businesses need to be investigated per day for possible outbreaks. We are currently monitoring multiple community settings with confirmed cases, such as workplaces and community exposures, including recreational sports teams and clubs, office settings, churches, and restaurants. We have known outbreaks in a few different community locations, including 2 separate hockey leagues and a processing plant. There are increased cases in schools and in childcare settings, and we're currently monitoring 22 schools and 2 childcare centers. Halton is also experiencing increased cases in congregate settings of long-term care homes and retirement homes. There are currently confirmed outbreaks in 4 long-term care homes and 2 retirement homes, with 38 cases in one setting and 20 at another setting. This excludes staff who live outside of Halton Region. Next slide, please. One of our primary roles is contact tracing. Our goal is to reach those who need to self-isolate and provide them with advice and supports to do so. However, with this second wave, contact tracing has become much more challenging. The steep increase in cases this fall has been accompanied by an increase in the number of contacts identified, those who must be notified of their exposure and managed appropriately. Only 198 high-risk close contacts were identified in August, versus 1,183 identified in September, and by the 19th of October, another 1,579 high-risk contacts already being identified, for a total of 2,762 second wave contacts to date. This does not include any of the cases as low-risk contacts. Staff have observed that compared to the first wave, cases in the second wave tend to have more contacts. While on average, cases from the first wave had 2 to 5 contacts, cases in the second wave have had many more, often greater than 10 contacts. However, this may include contacts at work, school, or on a sports team. This has led to some extreme outliers, with one school investigation involving over 100 contacts and a recent outbreak involving a hockey league involving roughly 300 contacts. In July, a new case and contact management system was rolled out by the province for COVID-19, building on the work Halton had completed to build our own case and contact management system. This provincial system replaced IFIS and has shifted data management to the frontline case investigator, which has resulted in the ability to reach less cases per day. All of these pressures have resulted in the need to find greater efficiencies. Next slide, please. Halton is working on rolling out several efficiencies to mitigate these pressures. We are ensuring each case receives a short initial call to let them know that they are positive for COVID-19, that they need to self-isolate, and to begin thinking about who their high-risk close contacts could be, so that it is faster for us to collect this information and then advise these contacts to self-isolate in order to reduce the spread of COVID-19 in our community. We are prioritizing cases under the age of 20 and over the age of 70, and cases associated with outbreaks to mitigate spread in high-risk settings, such as childcare centers, schools, long-term care homes, and retirement homes. We are working with the Ministry of Health to develop a way for cases to directly input their contacts to reduce investigator data entry time. We are providing letters to cases to reduce education time spent on the phone. And we are sending some of our identified close contacts to Public Health Ontario for further follow-up. We're also working with the Ministry of Health to find other case and contact management system efficiencies. Taken together, we hope that these changes will make our case and contact management work much more efficient. Next slide, please. So I'd like to conclude my presentation with a message to the public. I am asking residents to please be patient and kind to those who have been working tirelessly for many months now to protect the community from COVID-19. Whether you are speaking to a public health nurse from our call center, being assessed by your healthcare provider in a clinic, or being tested at the local assessment center, please be patient and kind with the staff person who is assisting you. We must continue to work together as a community and to support one another, more so now as we experience the second wave of COVID-19 in our region. Thank you for your time and attention today, and I'd be happy to take any questions that you may have.